Hello students, myself Dr. Mayur Jarag. I am Associate Professor in Pathology Department, Government Medical College Surat. Today we will learn about hemolytic anemia. What are the specific learning objective of this lecture is define and classify. We should learn that define and classify the hemolytic anemia. There are pathogenesis, clinical features and hematological indices of hemolytic anemia and pathogenesis, features, hematological indices and peripheral blood picture of sickle cell anemia. These all things we will learn in this lecture. First of all, hemolytic anemias are anemias in which there is an increased red cell destruction. As you know, normal lifespan of a red cell is about 120 days, and in hemolytic anemia it may become as low as 15 days. If the marrow can adequately compensate for the destruction, the patient does not manifest the anemia. But in moderate to marked hemolysis, compensation is not adequate and patients have clinical features of hemolytic anemia. Clinical and laboratory findings of accelerated red cell destruction and compensatory marrow regeneration. Remember, students, that the clinical features and lab findings are because of these two features, these two pathogenesis. That is, one, red cell destruction is accelerated and compensatory marrow regeneration. These two things lead to. Spleen is a main site of red cell destruction. As you all know, reticuloendothelial cells recognize the senescent RBC, abnormal RBC, and sequester them and destroy them. Destruction of the red cell is of two types. One is extravascular and one is intravascular. Remember that extravascular destruction is a site of destruction is mainly in the spleen, and it is exaggerated in hemolytic anemia. Hemoglobin is released and broken down into heme and globin. Iron is deposited within the marrow, and urobilinogen and stercobilinogens are excreted. So the increased hemolysis by extravascular destruction leads to increased bilirubin, that is unconjugated, increased stercobilinogen in the stool, that is dark color stool, increased urobilinogen in the urine, increased iron store, and increased LDH levels. Thus, other method is intravascular red cell destruction. This is a minor pathway of normal red cell destruction. Red cells are destroyed in circulation, releasing the hemoglobin. Free hemoglobin will bind to haptoglobin in this complex, is normally catabolized in the liver, but when plasma hemoglobin exceeds the binding capacity of the haptoglobulin, free hemoglobin passes into the kidney. Part of hemoglobin is absorbed by the tubular cells, were converted into hemosiderin, and when these are shed in the urine, it is called as a hemosideриnuria. Characteristic finding of intravascular hemolysis are hemoglobinemia, hemoglobinuria, hemosideриnuria, and decreased serum haptoglobulin. Now we will learn about sickle cell anemia. Sickle cell disease is an important hereditary hemoglobinopathy, a type of disease characterized by productions of defective hemoglobins. Hemoglobin, as you recall, is a tetrameric protein composed of two like pairs of globin chain, each with its own heme group. Normal adult red cell contain 96% of HbA, that is alpha 2 beta 2, 3% of HbA2, and less than 1% of fetal hemoglobin, that is alpha 2 gamma 2. Clinical significance of hemoglobinopathies result from mutations in the beta globin gene. Sickle cell anemia is usually caused by substitution of valine. The principal change occurs because of this reason, that is the substitution of valine for the glutamic acid as an amino acid in the 6 positions of beta globin chain, resulting from a point mutation. So the point mutation that will lead to this change, and this change will lead to hemoglobin A will convert into HbS. The abnormal physiochemical properties of resulting sickle cell hemoglobin are responsible for all these clinical features and disease of sickle cell disease. In this figure you can easily see how the HbA is converted into HbS, that is glutamine is replaced by valine in the beta chain. Red cell normal configuration, that is biconcave, and on deoxygenation it will turn out into sickled red cells. And you can see the end artery, because of microvascular occlusions there is an end organ damage, that is in the kidney, that you can see in this picture. Geographical incidence that is prevalent in Africa and Mediterranean countries and India. In India, it's a central belt, central horizontal belt is typically affected. That is Gujarat, Orissa, Andhra Pradesh, tribals of Madhya Pradesh and Maharashtra. 8% of black Americans carry this gene. In Gujarat, specifically the Dodia Patel, Kodi Patel, Gamit, Chaudhary and Wasawa communities are commonly affected. Sickle syndromes occur in three forms. One is sickle cell anemia, and second is sickle cell trait and sickle cell disease double heterozygous state. In sickle cell anemia, it is a homozygous state where both the genes are changed and HBS, and here and one abnormal gene is obtained from each parent, leading to both the genes affecting, that is HBSS, that is sickle cell anemia. Almost all of the hemoglobin is HBS type. Second is a sickle cell trait, when one abnormal gene from the father or mother and one normal gene is there. That heterozygous state of HBS, one gene is normal and one is abnormal. Only about 40% is the HBS and rest is the normal hemoglobin A. This is the basic difference between sickle cell trait and sickle cell anemia or sickle cell disease. First is the sickle cell anemia or sickle cell disease, and second is the sickle cell trait category, and third is a sickle cell disease with double heterozygous. What is double heterozygous? That is sickle cell patients will also have manifestations of thalassemia, that is called sickle disease. Pathogenesis. When deoxygenated HBS molecules undergo aggregation and polymerization, initially red cell cytosol convert from freely flowing liquid into viscous gel as HBS aggregates form. With the continued deoxygenation, aggregated HBS molecule assemble into a long needle-like fibers within the red cell and producing distorted sickle or holy leaf shape. So students, remember, a repeated deoxygenation and oxygenation process will make it irreversible positions of the cell. That's why on one deoxygenation this sickle cell may be converted back to a normal round shape, but if repeatedly this kind of deoxygenated episodes will appear, then it is permanently distorted. Sickling of red cell is initially reversible phenomena. On oxygenation, HBS depolarizes and the cell shape normalizes. However, with the repeated episode of sickling and membrane damage occurs, the cell becomes irreversibly sickle. Sickle cell lose the potassium and water and gain the calcium and have difficulty in maintaining normal intracellular. Number of factors that will affect the rate and degree of sickling. What environmental factors? That is, what environmental means, what are the total factors in addition to environment? Amount of HBS and its interaction with other hemoglobin chains. If the higher the HBS, it's more chances that it is become a sickle shape. Homozygous with virtually all hemoglobin S have full-blown sickle cell anemia. Fetal hemoglobin inhibits the polymerizations of HBS and hence newborns do not manifest the disease until the age of 5 to 6 months of age, when amount of HbF in the cell falls and close to adult level. So remember, children up to 6 months do not manifest a sickle cell disease because HbF inhibits. Okay, so the clinical features, or you will see the patients of sickle cell disease after the 6 months. Rate of HBS polymerization is strongly depend upon the hemoglobin concentration per cell, that is the MCHC. The more the MCHC, more the chances of rate of HBS polymerization. Thus the intracellular hydration which increase the MCHC, intracellular dehydration which increase the MCHC facilitates the sickling and vascular occlusion. Conversely, conditions that decrease the MCHC will reduce the disease severity. Here students, we should know that every sickle patient is advised not to become dehydrated by any means, whether they are suffering from diarrhea or any other illness, but they should not be dehydrated, otherwise their disease may be progress. A decrease in the pH reduces the oxygen affinity of the hemoglobin. And the fourth is the length of the time the red cell is exposed to low oxygen tension is also an important variable. What are the clinical manifestation of sickle disease? That is because of chronic hemolysis or ischemic tissue damage resulting from occlusions of small blood vessels. Okay. In this figure you can see the glutamic acid is replaced by valine that leads to HbA2S. Because of these HbS polymerize, and this kind of polymerized cells when blocked into end artery will lead to end organ damage. So what morphological change it will appear? The anatomical alterations are caused by chronic hemolysis, increased formations of bilirubin and small vessel stasis and thrombosis. Bone marrow is hyperplastic because of compensatory hyperplasia of the erythroid progenitor. Expansion of the marrow leads to bone resorption and secondary new bone formation, resulting in prominent cheekbones and changes in the skull that resemble screw cut in the raw angiograms. Extramedullary hematopoiesis can also appear. Spleen. Early phase in children, splenomegaly due to marked congestion of the red pulp due to trapping of the sickle red cell in the cords and sinuses of the spleen. Stasis, thrombosis, hypoxia and fibrosis and progressive shrinkage of the spleen. So in early adulthood, spleen is replaced by a bit of fibrous tissue called autosplenectomy. But students, you should remember this autosplenectomy in our setup, in our Indian setup of sickle cell disease. This autosplenectomy is not a feature. It is in Western countries and other countries it is autosplenectomy is there, but in Indian countries there is no autosplenectomy. Splenomegaly is the only present. So these are the features. You can see that the red pulp is congested. You can see the cut section. Infarction secondary to vascular occlusions and anoxia may occur in many other tissue like liver, spleen, kidney, brain, and retina, pulmonary vessels. Vascular stagnation in subcutaneous tissue may lead to leg ulcer in patients. As an other hemolytic anemia, increased breakdown of hemoglobin can cause pigment gallstone. All patients develop hyperbilirubinemia during periods of active hemolysis. What leads to the clinical course is a severe anemia, vaso-occlusive complications and chronic hyperbilirubinemia. Clinical features: age presentation between 3 months to 1 year, growth and development is delayed, spleen is initially enlarged. Infection: increased susceptibility to infection with encapsulated organisms has two causes. One is the splenic function is severely impaired. This is in Western countries, not in our countries. Autosplenectomy is not a feature in Indian setup. Secondary defects in alternative complement pathway impairs opsonizations of encapsulated bacteria such as Salmonella, Pneumococci and Haemophilus influenza. Septicemia and meningitis caused by these two organisms are the most common cause of death in children with sickle cell anemia. Other is the common hand-foot syndrome. Our patient usually present with this hand-foot syndrome, leg ulcers, pigment gallstones, and CNS occlusions of cerebral vessels, and priapism, stagnation of blood in corpora cavernosa. Hand-foot syndrome is bilateral painful swelling of the dorsum of the hand. It is a destruction of the phalanx, metacarpals and metatarsals because of vaso-occlusion due to sickling and dactylitis. Chronic hemolysis induces moderately severe anemia associated with striking reticulocytosis and hyperbilirubinemia. Crises in sickle cell anemia are of four types: vaso-occlusive crisis, sequestration crisis, hemolytic crisis, and aplastic crisis. Vaso-occlusive crises are usually called the pain crisis, are sudden attacks of bone pain, usually in the limb, joint, and chest and abdominal pain. Abdominal pain is also a very big common symptom, common clinical features. Although the infection, dehydration, and acidosis sometimes act as a trigger, in most of the instances, no predisposing causes are identified. Most commonly involved sites are the bone, lungs, liver, brain, spleen, and penis. In bones and bone necrosis due to Salmonella, or vascular necrosis of femoral head, that is in Western countries. Particularly dangerous are vaso-occlusive crisis involving the lungs. Renal insufficiency, papillary necrosis is also a common presentation. These are the, you can see, these are the sickle cell hemoglobins, breakdown of red blood cells, and you can see that breakdown will lead to physical weakness, anemia, heart failure, pain and fever, brain damage, spleen damage, impaired mental function, paralysis, kidney failure. Sequestration crisis occur in the children with a intact spleen. Massive sequestrations of the sickled red cell leads to rapid splenic enlargement, hypovolemia, and sometimes shock. Hemolytic crisis increased in the hemolysis with decreased HB and increased reticulocytosis. Aplastic crisis is a transient cessation of the bone marrow by erythropoiesis due to acute infections of erythroid progenitor cells by parvovirus B19 infections. Laboratory findings are anemia of moderate to severe type, that is 6 to 9 gram of Hb, anisopoikilocytosis, presence of sickled shape, polychromasia, target cells, normoblast, HJ bodies are usually a peripheral smear finding. Reticulocytosis is marked. Neutrophilia and thrombocytosis is the seen. ESR is a low because of sickle cell do not form Rowlets. Bone marrow, that is normoblastic hyperplasia. You can see that sickle, the word sickle is datardu. In Gujarati it is called as a datardu, the cutting weapon. Okay, grass cutting weapon, that is datardu, that is called a sickle. The name arises from that. You can see the sickled red cells over here. These are also the good pictures of sickle cell, sickled RBC. What are the diagnostic tests? Simple. At peripheral level, you can do PHC level, you can do the sickling test. Sickling is induced by in vitro by adding or reducing substance such as a sodium metabisulfite or sodium diethionate to blood. On adding, they will enhance the deoxygenation of hemoglobin and sickling of HbS. However, it will distinguish between the disease and the trait. It will not distinguish between the disease and trait. So it is diethionate test is simply, you can see on the figure here, you can see the first test tube on the left. So on the first test tube you can see that clearly line you can see over there. In the second you can't see the proper line, and in the third the black line behind the test tubes is you can never see. So this is the, remember, first is a normal, means on deoxygenations all the hemoglobins are dissolved and it is a clear. In second, the hemoglobins are partially dissolved, so there is a precipitate, however you can see the line, so it is not a partially precipitates are also there, but you can see the line behind, means HbA is present. And in last slide where you cannot see the black line behind the test tube, that test tube is made have a blood of sickle disease, that is homozygous sickle disease, that is that have only HbS and all the hemoglobin is converted into precipitates, and that's the reason why black line is not seen. Other ways of testing is a HB electrophoresis. Different normal and abnormal hemoglobin fractions have a different amount of negative charge. So these hemoglobin fractions under the influence of direct electric current, when applied in cellulose acetate agar or agarose gel, they will move with a different speeds towards the anode and leading to their separations and identifications. You can see this. The implications is when the positions where we have written the name, the AS, that is sickle cell trait, SS means sickle cell disease. On the near after the AS we have kept the hemoglobin molecule, and the movement is like that at the movement of S and A. So that is A and F. Adult hemoglobin is one who can go fast. So fastest is the hemoglobin A. So you can see the A, AS and SS. So order of hemoglobin fraction separated is HbA, F, S, D. Band of HbS is situated midway between HbA and A2. Band of F is lie between the A and S. HbS, 80% of HbS in case of homozygous disease, and AS it is 40%. HbF estimations and family studies are the other investigations by which you can see. Sickle cell trait means is a heterozygous state. Extreme low oxygenations as in acidosis, hypoxia due to aircraft flight, respirations, infections, anesthesia can cause sickling and vascular complication. Clinical features: impaired ability to concentrate the urine, protected from lethal effects of P. falciparum. Laboratory findings RAIN, but HbA and S, you can see the HbA is 60% and HbS is 35 to 40%. HbF is normal and HbA2 is slightly elevated. Friends, these are the students, you can see the first line is a implication line, and on the first two cases the hemoglobin is separated, means A band is there and S band, a lag behind band, that is S band is there. So this is in our setup we have done primarily. Nowadays the sickle cell investigations is being done by HPLC, that is high performance liquid chromatography. Remember, you have to write that high performance liquid chromatography is the final test for hemoglobinopathies. Any hemoglobinopathies, the final diagnosis is done by the high performance liquid chromatography. This is the features of, this is a photograph picture of HB electrophoresis. So HB electrophoresis, the higher version is HPLC, higher the final diagnostic is the high performance liquid chromatography. Okay friends, this is the hemolytic anemia. This in lecture we have learned about what is the hemolytic anemia, how the investigations differs, and commonest is the sickle cell anemia and sickle cell disease, and how we should diagnose them. Okay students, thanks a lot.